My presentation, The Tale of an Ancient Ally, Phage Therapy Part 2. This is a continuation of my prior lecture last year. Fortunately, the first year fellows weren't here for that, but on that presentation, thank you, Dr. McPartland. On that presentation, I focused my talk on sort of the basic science, some of the fundamentals revolving around phage therapy. And on this talk, my objectives are a little bit different. I'm going to go through a brief recap of the fundamentals of bacteriophage therapy just for the first years that weren't here for that first talk. So I'm making this like a little mini series. And then I'm going to jump into the basic science of bacteriophage antibiotic synergy, and that's going to be the focus of this talk, because more data is coming out of the pipeline on not only bacteriophage science and monotherapy, but combination therapy with antibiotics, and how that can have an impact, clinical impact, in treating some of these very MDR organisms that we're encountering. And then, some of the application of this type of synergy. And then I'm going to discuss a few examples of how they're using this technology right here, right now, in the 21st century, 2024, to treat actual clinical cases. So just as a quick summary of that phage therapy part 1, you can find this talk, I believe, has been uploaded to the ID podcast. And again, thumbs up and a big applause to our USF leadership, Dr. Euler, and everyone that's involved in creating this ID podcast. There's a lot of resources there, good talks, different discussions and presentations from our academic attendings, but as well from other guest speakers. So I highly recommend that you check it out. So as a summary, bacteriophages, as the name implies, these are phages. These are natural bacterial killers or eaters that are highly specific for different kinds of bacterial species. And in vitro and in vivo studies have shown that they have low inherent toxicity. So these are not necessarily chemicals that you're giving a patient with a lot of collateral toxicity. These are natural replicating particles that have evolved to target different kinds of strain of bacteria. So they're highly specific. They will not cause collateral damage to mammalian cells, and they have low inherent toxicity. So they're essentially druggable. Phages are abundant and easily discoverable. Again, these are natural replicating particles found everywhere. You can find them in natural reservoirs like water and soil and sewage. They're abundant in many places around the world and easily discoverable. A lot of institutions are building up libraries. They're going through the process of sampling and filtration and purification of the phages, and they're sort of building a library of different strains of phages. And then when it comes to phages, there are two main types, the lysogenic and the lytic phages. Lytic phages are the one that have been studied the most when it comes to application therapy. And the reason for this is that lysogenic phages, they tend to integrate. They form prophages. And when they become activated, they sometimes can spread antimicrobial resistance and genes among themselves and among different bacterial strains, and so we don't want that. So the lytic phages are sort of like your counterpart to bacteriolytic antibiotics. They act quickly, and their mechanism of action is well characterized. And then when it comes to phages, most institutions are moving away from monospecific bacteriophages or monotherapy with one single type of bacteriophage. They're using phage cocktails. And the reason for that is because with phage cocktails, you can sort of circumvent phage resistance development, and you can also expand the host range profile that you're targeting. When you get, as we all know, when you get an infection, not necessarily getting a single strain of a single bacterium. Sometimes you can have different strains and different heteroresistance of the same organism. And so with phage cocktails, you're able to expand your host range profile to produce better outcomes. And again, different phages in a phage cocktail can synergize. So a concept called phage to phage synergy, which is beyond the scope of this conversation. I'm going to focus mostly on phage antibiotic synergy. And then again, a lot of this technology was developed and was conceived and developed in the Soviet Union, and because of political reasons and the Cold War and things like that, a lot of this was did not get into Western technology or the Western hemisphere. But a lot of the studies coming out of Russia, Belarus, Poland, all these Eastern European countries have demonstrated that these can be given orally, superficially, IM, and IV with good systemic bioavailability. And again, unlike antibiotics or any chemicals, phages multiply over time. So when you give a drug, you know that these drugs have half-lives and volume of distribution, and the concentrations will decrease over time. With phages, you have the opposite effect. They multiply, and that creates a concept called auto-dosing, which produces very complex PK, PD, which is out of the scope of this conversation. But it's just something to keep in mind that you don't have to give repeated doses of phages. You can just give a one-time dose, because that one dose will multiply and out-of-dose, and they will distribute themselves using different PK, PD parameters. So that's the kind of a quick recap of that first talk. It's another reminder. This is the basic anatomy of a bacteriophage. Grossly, it can be divided into the head and the tail. And the head is essentially consisting of a capsid, a nucleoprotein head, which is called the capsid, which sort of encapsulates the DNA or the genetic material. The head is anchored to the tail by this collar, and then the tail mostly consists of a sheath that contains the tail tube by which the bacteriophage can integrate its genetic material into the bacterial cell. And then you have these tail fibers and spikes, which are essentially receptors that it uses to anchor itself onto the bacterial surface. So why am I talking about antimicrobial synergy, whether it is antibiotic, or phage antibiotic, or phage synergy? Why are we interested in synergy? And the reason for this is the rise of antimicrobial resistance. In 2014, the World Health Organization warned that a post-antibiotic era, which is pretty scary, meaning where antibiotics fail to target multi-drug resistant bacteria, is a possible thing in the 21st century. 5 years later, in 2019, you can find this on the CDC website. The CDC declared that through the antibiotic resistance threat report, that the post-antibiotic era is already here. In a report released by the UK Commission, they predicted that 10 million deaths per year at a cost of around $3 trillion per year will occur due to drug-resistant infections by the year 2050 or 2024. We're not too far away. We're going to encounter these problems during our practice as ID physicians. You can see here like a nice little graph of the U.S. In 2022, you have $2.8 billion in the antibiotic resistance market. You can see that across different infections, complicated UTIs, bloodstream infections, complicated intra-abdominal infections, media-acquired bacterial pneumonias, bacterial skin and soft tissue infections, hospital-acquired bacterial pneumonias, and C. diff, the overall trend is an increase in antimicrobial resistance, with a lot of, loss of productivity and loss of and costs. And the other thing is that traditional ways of drug discovery, right, are expensive in the billions of dollars and can take up 10 years. right? Finding the antibiotic in nature, in like some natural reservoir from some tree or some plant, purifying the antibiotic, modifying the antibiotic, going through the phase 1, phase 2, all these trials. They take a lot of time. And so at the end, and so ultimately you go through all that process, and bacteria will always, most of the time, will find a way to circumvent the antibiotics eventually, using their ability to mutate quickly, their adaptability. So there is a need to find different kinds of antimicrobials, or to enhance the antimicrobials that we already possess through the concept of synergy. And again, this is another nice little graph, which I found extremely shocking to me, that by the year 2050, pardon me, antimicrobial resistance will match cancer. So let's think about that in terms of deaths from drug-resistant infections. So this is predicted to skyrocket, and hence, we are putting a lot of money and effort and education into, our stewardship services and et cetera. But I think it won't be enough, just given the current trend. So we need to find other ways, or prepare at least, to come up with different concepts to be able to deal with the situation. So a lot of my presentation is going to be based off this article, which I recommend if you guys are interested in learning more about this. Be careful. I went down this rabbit hole of in vitro studies. So it's a good review, but don't. I'm just going to warn you. Don't go too crazy on it. But essentially, this is an article that talks about phage antibiotic synergy. I think it's a very important concept that I'm interested in, and I think we might be able to see that in our own practice become more and more standard, using a unique combination of antibacterial mechanisms of action and stoichiometry, which reminded me of Dr. Canella, who says that step 1 and pre-med and all that stuff always comes to bite your butt in ID, and that's kind of true. So I had not heard that word stoichiometry in a while. All right, so phage antibiotic synergy, or PAS, essentially, in terms of just basic overview of what this entails, is that there are different ways that you can have this phage antibiotic synergy. The first form of synergy is not necessarily synergy, but semantics aside, is having an additive effect, where the sum of the individual effects of the two agents is equal to their combinatorial efficacy. And you can see that on this first graph here, where the blue represents the drug, the red represents the phage, and the purple represents the combination. You can see that in the effect on the bacterial levels is additive when you have the phage drug combination. Synergism essentially refers to the total efficacy of the combination is much greater than each individual action. And again, you can appreciate that on this graph as well, where you can see that the phage antibiotic combination has more than an additive effect on bacterial levels, or the growth curve for the bacterium. And then there's also reported cases of no effect, which you can see here. There's absolutely no effect going on. And then there's also antagonism, and we will talk a bit about that, because it's something that we need to keep in mind. Whenever you combine a phage and an antibiotic, you don't always get the additive or the synergistic effect. You can get some antagonism. And again, that's where the rabbit hole of complex mathematics, PK, PD, and all that stuff can occur. But essentially, going back to the slide, whenever you have a combination of phage and antibiotics, and you put that together, and you essentially build a tighter play essay of that combination, you can create what is called a scenography, which is sort of a plot using heat maps and optical densities to determine, to better visualize the effect of the combination of a phage and an antibiotic. So pardon the busy slide, but I'm sure Dr. Kennedy will appreciate. So this is essentially a microtiter with different concentrations of the phage on the horizontal axis and different concentrations of the antibiotic on the vertical axis. And then left top corner, you have the antibiotic only effect. Then obviously on the left bottom corner, you have the no treatment effect. And then on the right top corner, you have the phage antibiotic effect. And then on the right bottom corner, you have the phage only effect. And essentially, this creates three regions, right? The antibiotic mediated killing region, which is mostly the regions above the dash line. So this region right here, this will be antibiotic killing region only above the dash lines. And then you have the region between the dash and the solid lines. This is the region that I'm talking about. This is the synergy region. This is this region right here. This is where you can find the synergy. And then the phage-mediated killing region, which is the region below the solid line right here. And this is just to show you an example of what I mean by this. Here, this is the phage. There's a Mayo HP3 phage. That's the name of this phage. And this is the antibiotic ceftazidime. You can see that they created a heat map using optical densities to determine the synergy between the different combinations of this phage and this antibiotic. And you can see that there is on this side right here, you can see the scale of percent reduction in the optical density, meaning the growth curve for that bacterium. And you can see that there is a lot of synergy or between the phage and the antibiotic, as represented by the sort of downtrend of the heat map as you go, as you move linearly across the interacting region here, with almost absolutely no, with complete eradication of bacterial growth in this region right here. This was a neat experiment that was carried out using wild type extraintestinal pathogenic E. coli. The reason why they chose the extraintestinal pathogenic E. coli is because these can be, these are inherently resistant to ciprofloxacin, some beta-lactams, and they can mutate quickly and acquire resistant genes quickly, and they're highly virulent. And this was another experiment that was carried out using a mutated strain of this extra intestinal pathogenic E. coli with a beta-lactamase, the CTXM14 beta-lactamase. And again, you can see that with the combination of the phage and ceftazidime, again, this strain should be resistant to ceftazidime. This is a beta-lactamase that should break down ceftazidime. With the addition of the phage, you essentially maintain this synergy, as you can appreciate by the downtrend in the heat map in the interacting region of the heat map. And again, this is another mutation that was introduced to produce a different strain of the same bacterial cell, which makes the bacterial cell even more resistant to ceftazidime by increasing the levels of the beta-lactamase. So it's a mutation that, quantitative mutation that increases the levels of the beta-lactamase production. Again, with the combination of ceftazidime and this phage therapy, it maintains synergy and maintains good bacterial killing. Again, you can appreciate that in the interacting zone right here of the heat map. So They and again, this paper is essentially a series of in vitro, in vivo studies using different formulas of antibiotics, using different um, uh, media as well to simulate in vivo environments. And they looked at different classes of antibiotics, and they also looked at different mechanisms of action of antibiotics. So they were asking themselves the question, um, what are the characteristics of this phage antibiotic interaction between different classes and different mechanisms of action from these antibiotics. And you can see that when they studied trimethoprim, this is not Bactrim, which is a combination of trimethoprim and sulfamethoxazole. This is the single agent trimethoprim. There was no effect. There was no effect between the combination of the antibiotic and um, and the um, and the phage. When they looked at colistin, uh, it showed a very interesting curve. And again, I highlighted the fact here that sometimes you don't have effect with the antibiotics that you choose to put in combination with phages. So this is something that can have clinical applications down in the future when this technology becomes more standard. But with colistin, you have this weird effect where you can have antagonistic effects and synergistic effects. And the change in the effect was when they increased the levels of phage. I believe for this graph, they use 10 to the 8th PFUs or plaque forming units of the phage. And for this graph, they use 10 to the 9th plaque forming units of the phage, and you obtain a synergistic effect, which was interesting. And I will comment on some of the mechanisms for that and what the authors think might be contributing to that. And again, you can appreciate the graph here, the combination of the colistin and the phage therapy in terms of the effect that it had on the optical density of the bacterial load, and it was a synergistic effect. With kanamycin, you sort of had synergistic and additive effects across the different dosages that they use. With Cipro, you have a similar effect a similar effect as colistin. You have the antagonistic effect, and then you have a synergistic effect. However, in this case, when you increase the dose of the ciprofloxacin, which again, this is it essentially showing that by changing either the dosages of the phage or the dosages of the antibiotic, you can manipulate the combination in such a way as you can produce synergistic effects, antagonistic effects, etc. With ceftazidime, you kept this synergistic effect across the different ranges of phage dosing and antibiotic dosing, which was pretty interesting to me. And the authors make a comment on that and why that happened. And so in terms of mechanisms of action with folic acid synthesis inhibitors such as trimethoprim, you can see that the interacting zone, which is the zone between the dash and the solid line, is very small. So essentially, probably Bactrim has no place in combination therapy, or at least the trimethoprim component has no place in combination therapy with phages. This kind of combination is mostly phage-mediated killing rather than phage antibiotic-mediated killing, as you can see by the bigger heat map below the solid line. With cell membrane disruptors such as ceftazidime, your beta-lactams, colistin, you can see that you have a little bit of interacting zone, a little bit, some good interacting zone here, but mostly you have antibiotic mediated killing, specifically with colistin. With ceftazidime is the opposite. With ceftazidime, you have a bigger interacting zone, and you have a lot of synergy with phage therapy. Again, with Cipro, it's kind of a Cipro has it's kind of a different complicated heat map. You can see that you have almost this stepwise. You can appreciate it here on this part of the graph, sort of a stepwise uh, downtrend in the heat map. So they called it a graded synergistic effect with ciprofloxacin. And then you can appreciate the different heat maps with the different uh, class of uh, antibiotics and their mechanism of action. I try to distill this as simple as possible. It's really, like I said, I went down this rabbit hole of very complicated mathematics, in vitro studies, but the concept is very interesting. The concept here is that not all combinations of phage antibiotics will have a desired effect. You can have no effect, as I presented with TMP. By manipulating the doses of either one, you can actually get some form of effect, whether it is going from antagonistic to synergistic or going from synergistic to antagonistic. And there's a lot of studies that are undergoing right now to determine the best dosing combinations for this kind of synergy. And with most beta-lactams, specifically ceftazidime, because that's the one that has been studied for whatever reason, that's the one that the authors have chosen, you maintain this synergism across a broad range of different phage dosing and media and antibiotic dosing as well. And I will comment on why that's the case. So with that little background, how can we apply this to treating antimicrobial resistance, to treating complex clinical cases, and extensively resistant organisms? Well, I touch a little bit on phage cocktails, which I discussed in more detail on my prior talk last year. And the reason for this is because with phage cocktails, you can target the concept of heteroresistance and the different mutational strains that can appear during an infection. And then I also discuss, we're currently discussing phage antibiotic synergy and how powerful that can be, as I demonstrated on that optical density heat maps that I discussed on my previous slide. There's other things that you can do. You can essentially use phages to insert enzymes into bacterial cells, and these enzymes will have a lytic effect on the bacteria by either destroying the cell wall or destroying proteins or destroying DNA. You can engineer phages to produce different kinds of effects. And then you can also use phage and CRISPR technology to essentially manipulate gene expression in bacterial cells and take out resistant genes, etc. So you can go pretty crazy with this technology and the applicabilities and all the different implications that you can get. And this was a study that was done on that from that article where it shows that by using a different kind of phage, in this case they use ES12, so they were using HP3 on the prior graphs that I demonstrated. By using a different kind of phage, you lose that interacting zone right here. So again, not just the dosing of the phage, but also the kind of phage that you use can also have an impact on the outcome of the synergy. And like I mentioned before, these studies are ongoing right now, and a lot of institutions are building up a library using these concepts to determine not only the best dosing, parameters, and routes of administration, but also the best phages known to target specific bacterial strains. And they're building that library to come up with formulations that eventually can be infused into patients. So how can we use this information and this technology and apply it in the clinical setting? Does this have a use that we can apply at the bedside now, or is this all theoretical? Well, I have good news. This is being applied now to many patients, not just in Eastern Europe, which, by the way, this is common practice, but here in the U.S. as well. So this is the case of a 42-year-old man who was admitted to the Hadassah Hebrew University Medical Center after a severe motor vehicle accident. He had multiple injuries in his lower extremities, bilateral open fractures. He had a left bicondylar tibial plateau fracture. He developed compartment syndrome from that acute fracture, had a right distal femoral fracture, and he was treated with external fixation, irrigation, debridement for the wound, and he had also fasciotomies for that, for that compartment syndrome. Unfortunately, on day 9 after his admission, he developed a skin soft tissue infection of the right proximal tibia and wound area, and they detected MDR, Klebsiella pneumonia, so KP for Klebsiella pneumonia. From the surgical, was detected from the surgical wound cultures. At 6 weeks after admission, he developed an infection of the left tibia with extensively resistant Acinetobacter baumannii, which you should be scared if you hear that. And also developed another infection with the same organism, MDR, so multi-drug resistant Klebsiella pneumonia. Had a very complicated long course, different kinds of antibiotics. He underwent serial irrigation debridements, placement of a cement spacer, etc. But essentially, he was treated with a prolonged course of antibiotics. 6 weeks of pit-tazo, high dose, 4.5 grams TID, followed by 8-week course of meropenem, 1 gram TID, and high dose colistin, 2 million units TID. He had, bone grafts. He had further fixation, had local irrigation debridement, had a lateral rotational gastrocnemius flap to fill some of those wounds. So he had adequate, pretty broad spectrum, pretty powerful antibiotics, and adequate surgical source control. However, despite aggressive irrigations, debridements, flat coverage, the wound got reinfected, it broke down, it hissed, and they essentially were able to isolate extensively drug-resistant Acinetobacter baumannii, resistant to carbapenems and colistin. So this is, a pretty heavy gun type thing. So eventually he ended up having surgical antibiotics above the knee amputation was recommended, but the patient refused. And at this point, phage therapy was considered because, as you can see, despite multiple rounds of broad spectrum antibiotic therapy that possibly could have treated some of these organisms, it just didn't do it for him. Acinetobacter baumannii became even more resistant, which highlights some of the points that I've been making about some of these, about bacteria species being able to mutate quickly, gaining fitness through adaptability, and becoming resistant to antibiotics. So they consider phage therapy, and this was an elegant study, by the way, and feel free to check it out. For this patient, essentially they used this patient as sort of a case study in phage therapy And they had to obtain special permission and all that stuff, and drug approval and all that stuff. But they were able to get the phages for this gentleman. And here on this first part of the graph, you can see the wound pre-treatment. Pre-treatment. This is prior to starting phage therapy. Dehiscence, bloody, draining. This is 2 weeks after treatment. And again, we're talking about MDR, Klebsiella pneumonia, extensively drug-resistant Acinetobacter baumannii that had mutated to become also resistant to colistin and all carbapenems. So 2 weeks post-treatment, and then this is 5 months post-treatment. So I won't go into the details of the graph, but I highlighted some of the most important areas here. You can see that when you add the combination of meropenem, colistin, and the phage, you have a decrease in the bacterial load or the bacterial growth. And this was carried out in the micro lab, obviously, of both the Klebsiella pneumonia and the Acinetobacter baumannii. You can see that when you with meropenem, right? With meropenem, the Acinetobacter baumannii is essentially persistent. There's no decrease in the bacterial load. When you add the phage, to that meropenem, you can see that there's a decrease in the bacterial load. And then this is when you use a mix of bacteria and phages. So not just one phage, but different kinds of phages. I cannot go into the details of that, very complicated. This is what they used for this patient, a cocktail of phages along with meropenem and colistin. And you can see the difference between the two here. You are essentially able to completely eradicate the growth of bacteria. And these are some of the plates and some of the pictures of the phages in vitro that they used. So the point here is when you use cocktails of phages along with antibiotics, in this case they use meropenem and colistin, you can get the results you want in vitro, but also in vivo, meaning eradicating the infection from the wound, as fortunately was able to accomplish for this patient, and getting the patient out of the hospital and back to regular life. And this is another case of a patient who unfortunately suffered with multi-drug resistant Acinetobacter baumannii, respiratory infection, pneumonia. And this is just kind of a brief timeline of what happened here. Again, these are very complicated cases with multi-drug resistant organisms. But the patient was admitted in 2020 and with respiratory distress, fever, chills, leukocytosis, consolidation. Sputum culture grew a multi-drug resistant Acinetobacter baumannii by hospital day 14. At this point, he was being treated with a combination of cefiderichol, daptomycin, gentamicin, and tigecycline. So this guy was pretty sick. On hospital day 19, they considered bacteriophage therapy because he was just not getting any better. And they switched the antibiotics to cefepime, sulfamethoxazole, trimethoprim, tigecycline, and they added the IV bacteriophage therapy. The sputum culture clear at that point. And then hospital day 13, they decided to go with an extended period of bacteriophage therapy because the sputum culture grew again, MDR, Acinetobacter baumannii. And so they extended that bacteriophage therapy, and as well they added this time cefiderichol, daptomycin, gentamicin, tigecycline, plus the IV bacteriophage therapy. Nice. Hospital day 35, they started nebulized bacteriophage therapy, which I think was pretty cool. And then they switched the antibiotics to cefiderichol, daptomycin, gentamicin, and tigecycline. At that point, all of his experimental drug therapies expired, but the cultures remained positive for MDI, Acinetobacter baumannii, So they consider another round of bacteriophage therapy on hospital day 46. Again, also IV and nebulized administration of the bacteriophage. So IV nebulized bacteriophage therapy along with cifidarical, daptomycin, gentamicin, tigecycline. And then once the bacteriophage therapy was completed, they switched the antibiotics to evercycline, meropenem, and polymyxin B. He was on hospital day 73, in December 9 of 2020. The patient was discharged, stable, all the physiologic parameters had stabilized, and the pneumonia was resolved. So yes, over 2 months in the hospital, multiple rounds of bacteriophage therapy. But again, this technology, it's in its infancy, and it highlights that it can help with combating some of these essentially DFTs, difficult to treat infections. So these are my references. And again, I'm just open for any questions or comments.